Mental disorders are one of the leading causes of disease burden and disability worldwide. And depending on how you track statistics and look at the metrics, some organizations like the World Health Organization will say, taken as a whole, they are actually the leading cause of disease burden and disability worldwide. So what are we doing about this? Well, we've got mental health treatment. These people need treatment. Let's get them treatment. And the reality is treatments do work. And these treatments save millions of lives every year. Unfortunately, they just don't work for everyone. The brain disorders that we call mental illness are actually metabolic in nature. And why do I say that? Because all of the risk factors affect metabolism. This is a way to integrate all of those biopsychosocial risk factors. And once and for all, it's a way to integrate what we call mental illness and physical illness. The CrossFit prescription can be a legitimate biological, metabolic brain intervention for people with real mental illness. So thank you, Karen, and thank you, everybody. So I'm going to talk about mental health. And in terms of disclosures, I have no financial relationships with anything related to what I'm going to talk about other than royalties for the book. So let's set the stage. In case you didn't know, we have a mental health crisis. Prior to the pandemic, mental and substance use disorders affected about 1 billion people on the planet in one given year. That represents about 13% of the world's population. Lifetime statistics are much greater. In the United States, about 50%, 1 in 2 people, will meet criteria for a mental disorder at some point or another during their life. And with the pandemic, rates are even higher now. Mental disorders are one of the leading causes of disease burden and disability worldwide. And depending on how you track statistics and look at the metrics, some organizations like the World Health Organization will say, taken as a whole, they are actually the leading cause of disease burden and disability worldwide. And the problem is not always a lack of treatment. For some, it's that our treatments fail to work. And there's this curious thing that's been happening over the last several decades. The rates of mental illness across a wide range of diagnostic categories have been increasing. Rates of autism spectrum disorder in the United States have quadrupled in the last 20 years alone. Rates of ADHD in the last 15 years, the number of prescriptions for stimulants in the United States has doubled. Double the rate of Adderall and Ritalin for the United States population in 15 years. And in case you didn't know, we've got an Adderall shortage now. Rates of bipolar disorder in adults have doubled over the last 20 years. In children and adolescents, they're up exponentially. And rates of plain old bread and butter depression, what has happened with them? The Gallup poll does an annual survey looking at current prevalence and lifetime prevalence. And in 2023, rates reached an all-time ever recorded high, both in terms of current and lifetime prevalence. So what are we doing about this? Well, we've got mental health treatment. These people need treatment. Let's get them treatment. And the reality is treatments do work. We have a plethora of medications. We've got lots of different types of psychotherapies, hospitalization, group therapies, electroconvulsive therapy, transcranial magnetic stimulation, ketamine, psychedelics, addiction recovery programs. And I want to be the first to say, there is no doubt these treatments do work for a lot of people, and these treatments save millions of lives every year. Unfortunately, they just don't work for everyone. Treatment resistance is common, affecting anywhere from 20 to 60% of all patients with psychiatric disorders. Why such a wide range? Because it really depends on the study and the population and how are you defining treatment resistance. But what we know is treatment resistance is common, and I would venture to guess each and every one of you knows somebody in your life or extended family who has a mental illness, who's taking medications and still not thriving. And that's because everybody will admit, yeah, our treatments don't cure mental illness. They are not disease-modifying therapies. At best, when we're lucky, they reduce symptoms. And this all begs the question, why can't we do better? And I would argue it's because up until now, our field has been unable to answer two fairly simple questions. The first is, well, what exactly causes mental illness? If you talk to the leading psychiatrists and neuroscientists today, most of them will say, yeah, that's a good question, nobody really knows. It's just too complicated. All we know are risk factors, and we put them into the biopsychosocial model. We say that there are things like neurotransmitters, genetics, hormones, but psychological and social factors, loneliness, trauma, that all come together to cause mental illness. Now, these biopsychosocial factors apply to all of the mental disorders, even schizophrenia and bipolar, depression, ADHD. So all of these things play a role. How do they fit together? Yeah, that's the complicated part. Nobody's been able to figure it out. The second basic common sense question that our field has been unable to answer is, well, what exactly is mental illness? Now, we have DSM, the Diagnostic and Statistical Manual, and it's got these labels in it that are household words that all of you know: schizophrenia, bipolar disorder, depression, anorexia, alcoholism or alcohol use disorder. And when I say these things, all of you get a clear picture in your mind probably about, yeah, I know what that is. Yeah, everybody knows what that is. But there are three primary problems with all of those diagnostic labels: heterogeneity, comorbidity, and a lack of validity. So heterogeneity says that if two people with the exact same diagnostic label can be wildly different from each other. So I could have a kid who's living in a group home because his parents can't take care of him. This kid bangs his head against the wall to the point of bleeding every day. So they put a football helmet on this kid. This kid also has seizures, and this kid has profound cognitive impairment. And we would say that this child suffers from autism. Somebody else with the exact same diagnostic label can be a billionaire businessman that we see in the news every day. Now, do any people in their right minds really think that these two human beings have the same brain condition? Comorbidity says that if you have one of these diagnostic labels, you're more likely to have another. Across the nation, in nationwide surveys, if you meet criteria for one mental disorder, 50% chance you meet criteria for more than one. Now, if you're actually getting treatment for a mental disorder, on average, you've got 3 to 4 different labels. So that means that if you've got schizophrenia, you're more likely to have OCD and an anxiety disorder. But if you have major depression, you're more likely to have OCD and an anxiety disorder. If you have anorexia nervosa, you're more likely to have OCD and an anxiety disorder. So even though we say schizophrenia and depression and anorexia are completely separate diagnoses, they have nothing to do with each other, when you look at real people with these disorders, they begin to look more similar than they do different if you actually really dive deep into the symptoms and diagnostic labels that they really have. And in fact, Tom Insel, who used to head the NIMH, and other leading neuroscientists have said, you know what? These labels are worthless. They describe symptoms, and yes, they do a good job of describing symptoms, but they don't do anything else. That when we look at the root causes, whether they be genetics or brain scans or blood biomarkers, that when we look at them, the disorders seem to have more to do with each other than they are different. And And so, under his leadership, the NIMH developed the research domain criteria. There are competing models. One's called the hierarchical taxonomy of psychopathology. Now, these models basically take a transdiagnostic look. And what that means is that they say, yeah, these mental illnesses all seem to share something in common, but we're not sure what it is, and it's weird, and we've got all these different symptoms, and so we'll just create these really complicated charts, hundreds of symptoms and ranges of symptoms, and that's gonna help us as a field. So as you can see, the mental health field is a mess. Heterogeneity, comorbidity, a lack of validity, and nobody can even really clearly say, well, what exactly is it and what causes it? There are several lines of research that are both shocking, but also offer, in my mind, tremendous hope. We have numerous lines of research that have looked at all of the genetic data, all of the neuroimaging data, all of the blood biomarker data, everything that we know about mental illness, all of the risk factors that increase risk. And these lines of evidence have suggested, beginning in 2012, that they seem to share something in common. So Dr. Leahy first proposed a general factor leading to all internalizing and externalizing disorders. But in 2018, another group of researchers, Caspi and Moffitt, looked at all of the labels in DSM. So autism, Alzheimer's, depression, alcoholism, anorexia nervosa. Looked at all of the labels and said, gosh, they all seem to share a common pathophysiology. And they labeled this the P factor. And then just last year, Brandt et al. Said, wait, hold on, guys. It's not just the mental disorders. These disorders seem to share something in common with a lot of physical disorders. Now, and they called it the D factor. This research couldn't tell anyone what the factor was. So people are wildly speculating. Lots of researchers are saying there's no way there could be a factor, a common factor. So there's a lot of debate in the mental health field around this research right now. Like, what could it be? And does it even exist? Was that research really legit? Like, that seems impossible to believe. And what I am going to stand in front of you and audaciously say is that I think I know what the P factor is. And I am going to argue, so no, this is controversial, but I am going to argue that in fact the P factor is metabolism or metabolic problems. That mental disorders, the brain disorders that we call mental illness, are actually metabolic in nature. And why do I say that? Because all of the risk factors affect metabolism, that metabolic dysfunction in cells can help us understand why the brain would malfunction and result in the symptoms that we call mental illness. This is a way to integrate all of those biopsychosocial risk factors, and once and for all, it's a way to integrate what we call mental illness and physical illness. So now I'm going to walk you through just a tiny snapshot of the evidence to support this. I want to make clear there are decades and decades of research that support this model. I'm going to give you just a tiny snapshot in the next minutes that I've got with you. So the first one is I'm going to start with correlations. Correlation doesn't equal causation, but when we see strong bidirectional correlations, we need to consider a common pathophysiology. What do I mean when I say bidirectional? So mental illnesses have strong bidirectional relationships with all of the diseases on the right-hand side of the screen: obesity, diabetes, cardiovascular disease, and Alzheimer's disease. So when I say bidirectional, what does that mean? It means if I go to a mental health hospital and look at people with mental illness, they are more likely to currently have or in the future develop obesity, diabetes, cardiovascular disease, and Alzheimer's disease. But what if I do it the other way around? What if I go to a Weight Watchers group they're more likely to have a mental illness. Diabetes clinic, cardiovascular clinic, nursing home for Alzheimer's disease. Let me give you just a snapshot of some of these statistics. People with chronic mental disorders, 2 to 3 times the rates of obesity and diabetes, higher rates of cardiovascular disease, ranging anywhere from the low of about 50% up to about over 200% increased risk, depending on the diagnosis. Alzheimer's disease. People with chronic depression, 2 to 3 times the risk of developing Alzheimer's disease. People with schizophrenia, if they live to the relatively young age of 66, they have a 20-fold increased risk of also having dementia on top of their schizophrenia. What about the other way around? Obesity. People with obesity, 50 to 350% increased risk of having a mental illness. Which mental illness? All of them, or almost all of them, across the board, across the lifespan. Diabetes, 2 to 3 times the rates. Cardiovascular disease, 3 to 5 times the rates. Alzheimer's disease. Essentially, all people with Alzheimer's disease will have symptoms of mental illness. They will have depression, anxiety, ruminations, agitation, insomnia. 40 to 50% of them will have hallucinations and delusions. Those are the hallmark symptoms of what we call schizophrenia. So I want you to think about what I just shared with you. If you have schizophrenia, you have a 20-fold increased risk of developing premature dementia. And if you have dementia, you have a 50-50 chance, that's about a 50-fold increased risk, of having the hallmark symptoms of schizophrenia. We can't talk about the root cause of mental illness without talking about the root causes of these other disorders. And in fact, metabolism is much more than just those disorders. Metabolism affects every cell, organ, and tissue in your body. And this large population study of over 6 million people that looked at people who were first diagnosed with a mental illness, what's the likelihood that they will develop another physical illness, dramatically increased risk across a wide range of physical health disorders, including all of the metabolic ones that I just shared with you, but also autoimmune and other diseases. And in some ways, this is kind of nothing new. So we've long known that people with serious chronic mental illnesses die early deaths. Anywhere from, they have a lifespan reduction anywhere from 7 to 30 years, depending on what diagnosis, what population, what study we're looking at. Now a study just published in 2019 suggests something a little more alarming. Wait guys, it's not just those serious things like schizophrenia, it's all of the mental disorders. Each and every diagnostic label in DSM-5 is associated with a reduction in lifespan. On average, men are losing 10 years of life, women are losing 7 years of life. What are these mentally ill people dying of? Everybody thinks suicide. Yes, they are more likely to commit suicide, and yes, that does play a role in these statistics, but the number one cause of death in these mentally ill people dying early deaths are heart attacks and strokes. Why? Why are the mentally ill dying early deaths? This has not gone unnoticed. There are a lot of people who are worked up about this. They want to do something about this. World Health Organization put together a task force to try to figure this puzzle out. What did they conclude? It's factors related to the individual's behavior. That means the mentally ill overeat and underexercise. Or it's maybe medication side effects. Maybe it has to do with that. It's problems at the health system level. The mentally ill don't go to their primary care doctors and do what they're told. It's wider societal issues. The mentally ill are more likely to be poor and unemployed. Poor, unemployed people die early deaths. We know that from large population studies. So maybe it's that. Maybe it's like the social determinants of health. In my mind, this is about ignoring science, and it's about blaming the victim. Overeating and underexercising, whatever that is a symptom of metabolic poor health. Blaming them for not going to their primary care docs, blaming them for being poor, blaming them for being unemployed, is about blaming them. if the mentally ill just tried a little harder. And you all know somebody who's mentally ill. Whether you use that language, whether that language makes you cringe, I use it not to be pejorative. I use it because that's the way we break stigma, is to say it out loud. That is what people are thinking. Yeah, my nephew is just a lazy, no-good slacker. He's on all those pills. His parents pamper him. He's in trouble at school, and he's getting fat, and he's lazy. That is what we think. That is the thing we tell ourselves about why the mentally ill are dying early deaths. And what I'm here to say is we are, in fact, missing the elephant in the room. Because metabolic problems have been identified in the brains and bodies of people with mental illness for over a century. In the 1930s, researchers found abnormalities in lactate and glucose metabolism in people with bipolar disorder and schizophrenia. There is now a plethora of basic science neuroimaging studies to support this. The diagnoses are across the board: depression, anxiety, PTSD, schizophrenia, bipolar, anorexia, alcoholism. What do I mean when I say metabolic problem? I mean that when we look at brain scans or cell biology or blood biomarkers, that people with mental illness on average have differences in lactate or glucose metabolism or the ATP to ADP ratio, or reactive oxygen species redox markers, levels of NAD to NADH, inflammation, and all of these other things. I want to be clear, because a lot of people think in terms of linear relationships. So Dr. Palmer, are you saying that like all mentally ill people will become obese? No, I'm not saying that. I know some thin mentally ill people. Dr. Palmer, are you saying that all obese people are mentally ill? No, not saying that either. Just like I'm not saying all obese people have heart attacks, and not all heart attack victims are obese. But they do increase the risk for each other. And we need to start thinking about mental illness in the same way. And instead of linear relationships, we need to think in terms of complex feedback loops. So most people still have simplistic notions of what this is all about. So mental illness on the top is either a chemical imbalance, so that's a neurotransmitter issue, or it's about trauma and stress. And you need psychotherapy. And it's really that simple. It's a neurotransmitter or it's trauma and stress. And therefore the treatments are straightforward. Take a pill or get therapy. And that's what mental illness is. Metabolic illness, obesity, diabetes, cardiovascular disease, that's a problem of diet and exercise. If everybody just did the right diet and did the right exercise, we would just stamp out all metabolic illness. Well, neither is so simple. We've long known that there's a both category. Genetics and epigenetics play roles, hormones, inflammation, sleep, the gut microbiome play roles. And what I'm here to say is that we need to integrate all of it. Trauma and childhood stress increase risk for all mental disorders, essentially all of them, but they also increase your risk for obesity, type 2 diabetes, cardiovascular disease, and premature mortality. And we call those social determinants of health. I'm not making this stuff up. But it goes the other way around. Should we be thinking about diet and exercise to treat mental illness? Well, that's this ridiculous fringe field called nutritional psychiatry or that's crazy talk. And what I'm saying is that it's all integrated. So I'm saying metabolism, metabolic. What is metabolism? A lot of people have this simplistic notion, it's burning calories. Well, yeah, it kind of is, but it's a lot more than that. Metabolism, a simple definition, the process that all living organisms use to convert food into energy or building blocks to maintain or grow cells, and it also involves the management of waste products. It is fundamental to the definition of life. It is ridiculously complicated. Hundreds and hundreds of different metabolic pathways, enzymes, hormones, all sorts of things are playing a role in metabolism. So now in this sense, Chris Palmer, you're saying mental illness is somehow or another related to metabolism, and you're going to say metabolism is essentially everything in biology. Well, that's not really all that helpful. Sure, we'll give you the metabolism thing, but you're not telling us anything useful. So if you ask another common sense question, well, what exactly controls metabolism in the human body? What controls it? If you really do a deep dive into the science, and this science has exploded in the last 20 years. So this is going to defy, if you have not kept up with mitochondrial biology in the last 20 years, this is going to defy everything you were ever taught by your science teachers. But I am arguing that mitochondria are the central regulators of what we call metabolism. If you even know the word, and you even know something to pair it with in a multiple choice test, you know they are the powerhouse of the cell. But they are actually so much more than that. There are hundreds or thousands of them in each cell. They are highly dynamic. They move around cells. They fuse with each other. They form conformations around the cell nucleus that determine how a cell develops, that determine which genes are getting expressed. And in fact, if you do a super deep dive into the science of mitochondria, they are the unifying link for all of the risk factors that we know play a role in mental illness. They play a direct role in the production, regulation, and release of neurotransmitters such as serotonin, dopamine, GABA, and glutamate, but those neurotransmitters impact their function. They are primary regulators of what we call epigenetics, or the expression of genes from the cell nucleus. They play a role in turning inflammation both on and off, but infections and inflammation impact their function. The gut microbiome affects mitochondrial function. Shockingly, mitochondrial function affects which microbes exist in our guts. Same with diet, exercise. Diet and exercise play a profound role on mitochondrial biology, and I would actually argue diet probably is one of the more central things within our control. I mean, we can't control our genes and epigenetics as easily, but we can control our diet. But actually, mitochondrial function in certain brain cells control whether you feel hungry or full. Adverse childhood events, stress and trauma impact mitochondrial biology directly. Drugs and alcohol, sleep deprivation. Hormones impact mitochondrial function. And mitochondria control the first step in the synthesis of some hormones that maybe some of you have heard of. They include cortisol, estrogen, testosterone, and progesterone. So if you have dysregulation in any of those hormones, you must implicate something going on with mitochondria in order to understand why those hormones might be dysregulated. So that's a theory. It opens up a lot of new possibilities for exploration. Some are arguing there's more than enough evidence to support the outline that I've presented. Others are saying, well, we don't buy it. That's okay. New disruptive theories take time for everyone to accept. And in fact, I believe that a new disruptive theory has a chance to advance the mental health field and improve lives for millions of people. But I have always been a clinician as well as a researcher and educator. And so I'm really interested, well, what can we do today? And I am arguing that we can offer a new approach to treatment. I am not here to say there is a simple solution for all people with mental illness. I'm not here to say that if everybody just exercised, we would stamp out all mental illness. Not saying that. So there are lots of things. The current treatments will still play a role for many people, medications, psychotherapy. But social connection, employment, housing, meaning and purpose in life, that starts to sound like community. Diet, nutrition for a mental illness, huh? vitamins and supplements, metabolic medications, lots of opportunities. And I could talk endlessly about all of these and how they all fit in to a metabolic theory of mental illness. But I'm going to focus on two that are probably of relevance to all of you. So exercise, number one, can exercise play a role in mental health? We know that people who exercise, this is a large population study, over 1 million people, people who exercise are more likely to have good mental health or less likely to have poor mental health. This is an association study, meaning it's correlation. And the confounding variable in this is it just that mentally ill people are already like unmotivated or there's something wrong with them so they don't exercise, and healthy people are just more likely to exercise? So this doesn't prove causation. It doesn't tell us exactly how the relationship goes. And in fact, if you talk to mental health professionals or epidemiologists or other things, you're going to get in an argument about whether exercise alone is an effective treatment for mental illness. Because in fact, exercise alone in most of the studies is not a good weight loss. It's not a good weight loss tool. If you take a group of overweight, obese people and you simply have half of them exercise, no changes in diet, no changes in sleep, no changes in all the other stuff, you just have them exercise or not exercise, the long-term outcome studies are actually abysmal. It doesn't do much. And data on mental health outcomes is primarily from small, poorly controlled trials. And there was one meta-analysis of all of the studies of exercise for depression, and they actually said, no effect. It doesn't do anything. They looked. It doesn't seem to do anything at all. So that might match the weight loss and diabetes studies that we've got. Now, the World Health Organization takes a more positive view. They say, no. We reviewed that same evidence, and we think that there is evidence for the benefits of physical activity in depression, schizophrenia, dementia. But if you try to get in an argument or debate with a healthcare professional, just know that they can pull a study out that's going to say it doesn't really do much, so don't talk to me about exercise. So why? Why would exercise not work? Now, we heard this. You heard the presentations this morning. Exercise is great. Exercise is wonderful. And I'm not here to say that's not true. It is true. But I want to give you just two examples of the nuance. Why would exercise not work? Why might it take longer for it to work? One is the problem of insulin resistance. So this was a study where they took 36 volunteers. It's a small study, but it was published in one of the most highly reputable biological journals called Cell. And they took 36 volunteers and they measured a plethora of metabolic, cardiovascular, immune system biomarkers before and after exercise. And what they found is that, yeah, exercise is tremendously beneficial for people who don't have insulin resistance. And for people who have high levels of insulin resistance, those same biological pathways seem to be mitigated and or sometimes even reversed. So this says insulin resistance might reduce the effectiveness of exercise. So what should we do? Let's put everybody on this diabetes medicine called metformin, right? Because that's what we do. We put them on metformin. So what happens with exercise and metformin? Now, this was a randomized controlled trial, middle-aged adults, 61 to 63. They were all assigned to a 12-week aerobic exercise treatment program. Half of them got metformin and half of them got placebo. And then they measured a wide variety of things like fasting, insulin, and whole body insulin sensitivity, and VO2 max, and other things. And metformin alone This was not indicated. This was a randomized controlled trial in people who supposedly did not need metformin when they took metformin. They did get some benefits, like decreased fat mass, improvement in hemoglobin A1C, fasting plasma insulin. But metformin attenuated the improvement in whole body insulin sensitivity and VO2 max. And metformin abrogated, meaning pretty much wiped out, the exercise-mediated increase in skeletal muscle mitochondrial respiration. And one of the benefits of exercise is increasing VO2 max. What is VO2 max really measuring? If you don't know this, it's measuring your mitochondrial health and density. Because mitochondria are the only things that are using oxygen in the human body. So VO2 max is a direct measure of mitochondrial health and density. And we heard earlier today, it's a good thing, right? That's good. So we want to improve it. Diet. So I want to be the first to say, there is no one-size-fits-all dietary intervention for all human beings. Depends on who you are, what health conditions you've got. Some people need to lose weight, other people need to gain weight. You might need to address nutritional deficiencies, remove allergens, toxins, chemicals, healthy diets, gut microbiome plays into this, changing metabolism. Dietary interventions gets ridiculously complicated. But I'm not just a health and wellness guy. I'm not here to say, eat more broccoli, and that will cure your schizophrenia. That's not what I'm saying. So I want to just spend my remaining minutes on the ketogenic diet, which is a metabolic treatment. So most of you know what keto is. In many ways, the CrossFit diet can be easily modified. Meat, low-carb vegetables, seeds and nuts, no starches, maybe some fruits like avocados, and no sugar. So it's a modified CrossFit diet. It mimics the fasting state. This is an evidence-based treatment for weight loss, type 2 diabetes, and importantly to me as a psychiatrist, this diet stops seizures even when medications fail to. And we use seizure treatments in psychiatric patients every day in tens of millions of people. How does a diet stop seizures? We actually know more about this diet and its effects on the brain than we do any other dietary intervention. Tons of neuroscience on it. Does it work? This was a randomized controlled trial of the ketogenic diet for alcoholics, done by the national government under the direction of Nora Volkow, who is the director of our National Institute of Drug Abuse. They took a group of alcoholics, admitted them to a detox unit. Half of them got ketogenic diet, half of them got the standard American diet. 3-week trial. Patients who got the ketogenic diet had fewer withdrawal symptoms, required fewer benzodiazepines for their detox, had fewer cravings for alcohol, had improved brain metabolism, and reduced brain inflammation. Schizophrenia, bipolar, and depression, which is really my area of research. Patients are putting their schizophrenia and bipolar disorder into remission off of psychiatric medications using ketogenic therapies. I'm really proud to say that I got a large grant to start the metabolic and mental health program at McLean Hospital and Harvard Medical School. This field is exploding. We have research trials being conducted around the world. And I just want to put a plug into all of you. You all could do a lot of this. You don't have to treat schizophrenia. I'm not asking you to sign up to treat schizophrenia. You could maybe dabble in the mild anxiety, depression, maybe a little ADHD in this teenager. And what I'm here to say is it doesn't matter what the label is. You, the CrossFit community, could help a kid overcome his ADHD by improving his metabolic health, which will improve his brain function, which will allow him to not play into the Adderall shortage that our nation is experiencing. He could be a good patriot and let Adderall be for the other people. Likewise, for antidepressants and anti-anxiety and sleep medicines and everything else, the CrossFit prescription can be a legitimate biological, metabolic brain intervention for people with real mental illness. I'm not talking just the people who are just a little burned out. Yeah, it helps them too. That's great. It's great for the people who are burned out. But I'm talking people with legitimate, diagnosable mental illnesses. You can play a powerful role. And with that, I thank you.